The Kaiser Family Foundation presents health08.org, election news, analysis, and events.
Jack Lewin, thank you for being here with us today.
Pleasure to be here.
The college, the cornerstone of the college's reform plan is something called Quality First. What is that about?
Well, to get at quality first, maybe I should say in preface that the college supports expanding access to care to cover all Americans and to fixing the problems of the underinsured as well. We certainly believe that we've got to slow the rate of cost increase in healthcare and focus on efficiency. But we think the main area of responsibility and accountability for physicians and other professionals in healthcare is to deal with the quality of care issues that only we can fix and handle. So Quality First is about reaching inside the healthcare systems and processes, care delivery, and to improve quality of care through application of guidelines and performance measures at the point of care, through adoption of electronic medical records and clinical decision support systems through which the guidelines and performance measures we so painstakingly develop are actually applied to patients in a systematic fashion. And through then taking the information, measuring how we're doing, and giving continuous quality feedback to clinicians to improve quality, and then educating around specific measured deficiencies in care. So Quality First is really a whole comprehensive package of translating science into guidelines and performance measures, which the college, by the way, has done for 25 years with the American Heart Association, and in a very sophisticated way. Then embedding those measures at the point of care so that they're applied to every patient, measuring the extent to which quality outcomes and performance measure adherence really occurs in the system, and then educating around measured gaps.
And so much of what you've just described can, and I presume is being driven by the profession itself. But when it comes to the larger issues where you started out with access to care, affordable care, etc., where does the college land in terms of what the federal government, particularly a new administration, should be looking at?
Well, we're lobbying to create a system of universal access and universal coverage.
By what means?
Well, we don't believe that physicians are going to be called to the table as the economists to decide how society chooses to finance these challenges. I think we are there to help advise in any way that we can. But these are societal issues. I mean, how we finance access, or when we finance access to care for those who aren't covered or who are underinsured, is something that we have to decide as a nation, as a society, through Congress, through state legislatures. And quite frankly, physicians and nurses are probably not going to be central in some of the key decisions there. The desire to do that may be something we can push for, but how we finance it and the specifics of how we do it will be much broader kinds of discussions and decisions that will involve all of us and should involve all of us, patients as well as doctors. We hope for a patient-centered system that is based on evidence and science, and that is, if you will, embedded with continuous quality improvement and transparency in those regards, so that everybody can see how we're doing, can choose to participate in a care delivery system that is actually achieving higher quality performance.
But certainly the financing of the system impacts, number one, the access to the system, number two, the quality of what the patients get. Sure. So I guess I still want to know what the college feels. I mean, I presume not a single payer plan.
There are members of the college, like in any constituency, that would like a single payer, but not the majority. The college would like a public and private system, a pluralistic system, much as we have now, with some of the problems in it fixed. We would in fact see some positiveness in continuing employer-based coverage if we could fix some of the deficiencies in employer coverage, such as making employer coverage portable, such as ensuring more choice in employer coverage. And that might be achieved through purchasing cooperatives, for example, and through some other mechanisms that would provide the benefits that often are described around the individual coverage, for example. We believe that the funding for this needs to be divided up among constituencies. Individuals are going to be responsible for a significant part of the care. Employers could be the accountants and also contribute to the care like they do now. And government obviously has a significant role. So we'd see it pluralistic in terms of a public-private system, a system funded by individuals, employers, and government in some organized and consistent fashion, and a system that gives people choices and options for care that meet their needs.